All right, so I think it looks like we have a good number of people here. Thanks everybody for coming out tonight. I'm Dr. Nicholas, if you haven't already met me. I'm one of the MS specialists here at OhIoHealth in the MS Center. And I'm happy to be here tonight to talk to you about some very important symptoms that people with MS deal with. And so hopefully this will help give some insight into how there might be techniques or treatments that might be able to help you, or just more information on the disease itself. And then when we finish the slides, I'm happy to answer any questions. If you have burning questions as we go along, though, please feel free to raise your hand and we'll go through it. Want it to be as interactive as possible. So before we get started tonight, does anybody have any major questions about bowel, bladder, or sexual dysfunction that they want answered? So I make sure I cover it. Yes?
I'm just having trouble with the sexual dysfunction part. I'm going to see if you're already covering, but...
Okay. All right. Yes?
My concern is UTIs. I have a catheter,
Mm-hmm.
and since I have the catheter, I haven't had the problem so bad. But that's one thing that bothers me, is I never know when they're going to flare up.
Yeah, and those can definitely make your symptoms a lot worse. So we'll make sure.
In the hospital too, and I don't like that.
Yeah, that's definitely something we want to avoid. So that's something we can talk about as well. Okay, so we'll go ahead and get started. So there are a lot of issues that can occur with the bladder when you have MS. And it's mainly related to the fact that MS can cause lesions within the brain and the spinal cord, and it can interrupt the tracts that actually control bladder function. The bladder is a muscle, and so just like other muscles in MS, it can become weak, it can become stiff or spastic, and it can also have lots of spasms. And so how many people sometimes feel like they're the I gotta get there right now commercial? I know it's a little bit old, I haven't seen it in a while, but that's what I always think about. And so that's when that bladder muscle, just like other muscles that you have where your leg might be cramping up, that bladder muscle is repeatedly cramping, and that makes you have that frequency and feel like you have to go all the time. And so that's something that there are a lot of treatments that are targeted to. And so you probably heard this term neurogenic bladder. That's really just a fancy doctor word that means bladder problems due to a neurologic disease. So it's not isolated to MS. There are lots of other neurologic conditions that can cause bladder problems. And it's very important that if you're having any of these issues that you bring them up with your neurologist. And also, if the techniques or attempts that have been made to help your bladder symptoms aren't working, then you may request a referral to a urologist, because they often have more in-depth testing than we can do in the neurology clinic, and a lot of other additional knowledge and tools. And so we'll cover some of that today. I think this is an interesting quote here. So this was from the NARCOMS data that actually questioned how many people who have MS have some type of bladder problem during the course of their disease. And you can see that this is very, very high, so 80 to 96%. And although bladder symptoms are not the most common presenting symptom of MS, it could possibly be the first symptom somebody has. But oftentimes we see that it's more common as time goes on with MS, and it can worsen over time with the disease. So there are really two main problems. Problems with eliminating or emptying urine. And so sometimes you feel like, oh my gosh, I have to go so bad. You get in there, you sit down, or you stand up and try to urinate, and nothing's coming out, but you know that it's in there. So you wait, maybe you run the water, try all these kinds of tricks. Sometimes people do the Credé maneuver where you put your hand over your bladder and lean forward, try to push it out. But that can be really annoying and hard, especially when you've got to be back out to your job at work or meet up with your family or something like that. And certainly problems with storage where you feel like you're going too frequently, and you're having these sudden urges, or you're having incontinence. Those are all important issues, and many people with MS can have a mixed problem, so where it's actually both problems at the same time. And so how do we deal with that? So I don't want to put you to sleep, so don't worry, I'm not going to get too much into the science here, but I think it's important to realize the connections and how this happens. So this is a nice picture up here, obviously, of the brain and the spinal cord coming down. And the central nervous system basically has this control over the bladder muscle, which is called the detrusor muscle, as well as the sphincter muscles. And then the urine exits through the urethra. And so when there's some type of inhibition of those nerve signals, that's when you can have bladder issues, as we mentioned, either problems with emptying, storing, or both. So these are the major problems that I see in MS neurogenic bladder. And I like this picture because this is what a lot of people tell me it's like when they're at work or out and about. They're always they know where the bathroom is and they try to find it. And I think, gosh, that's really hard. We need to do something about that because that's embarrassing. And sometimes people, when they have these issues, they don't want to go out and about as much because they're worried they're going to have an accident or they might not be able to find the restroom in time. So urgency is when you have that sudden urge. You feel like you have to go now or you're going to have an accident. Frequency, obviously, is when you're going too frequently. You don't have much of a break between. That can happen, again, as we talked about, when that detrusor muscle, that big bladder muscle, is contracting too frequently. And it can also happen when somebody has a urinary tract infection, or even if somebody has retention. So if you're not emptying completely, and you go and you empty, and then you still have a lot of residual urine in your bladder, that urine will get back up to the set point where you have to go again a lot quicker if the bladder is not emptying completely. And so it's not as simple as just listening to the symptoms that you have and putting you on a medication. It's actually very important that if you have bladder symptoms, that we also look at a couple of things. We want to look and make sure that you don't have a UTI, because if you have a urinary tract infection, that can set off a lot of these symptoms or make them worse. We also want to make sure that we know if you're emptying okay or if you're retaining. And so one of the best tests is just a really simple bladder scan or bladder ultrasound in the clinic. And most neurology clinics have these, and all that really involves is just having the nurse do a little ultrasound over the pelvis where your bladder is. And I always tell my patients, hopefully we don't find a baby in there. We're just looking to see how much urine you have. And then once you empty, we'll repeat the scan and we'll look and see how much urine is left. I've never found a baby that way, fortunately. So urinary incontinence, this is a big deal. So urinary incontinence is not always having that problem where you have this big gush of all the urine in your bladder coming out, although that certainly happens. But it can also be that slow leakage of bladder, so where you feel like I need to wear a pad when I go out, or I need to wear pads every day because I'm worried that it might happen. And so that can happen for a number of reasons. Again, certainly if you're going too frequently, you've got the urges, you've got to get there quick, or if your bladder's filling so much and it's just kind of leaking out because you've got that big, bulky, leaky bladder. Certainly in the setting of urinary tract infection, that's more common as well. And we also see that certain medications that we use for MS sometimes can make this worse. So if you take muscle relaxers because you've got stiff muscles, but the muscle relaxers relax your bladder muscles too much, you may be more likely to have urinary incontinence. And so that's something that we want to look at and see, maybe we can decrease that dose a little bit because you may really need the muscle relaxer, but maybe we've just got it too high, and so that's made things a little bit worse. We also, it's important to know whether are you sleeping okay? How many times a night do you wake up to urinate? If you're waking up at night to urinate a lot, and you're not chugging a gallon of fluids before you go to bed, then that can be really annoying to wake up that frequent, and it's hard to fall back asleep. And then with MS, you already have fatigue, and now you've been up all night going to the bathroom and back, and then you're tired for multiple reasons. So there are treatments that can help, particularly for people who are waking up frequently at night to urinate. And there are lots of behavioral techniques that we'll talk about that might be able to help that as well. So urinary retention, so that's when you have trouble with emptying. And so there are specific medications that we're going to talk about that actually help to empty the bladder. Some of the medications that work the best are actually medications that we even use in males for enlarged prostates, but they actually help men and women to empty their bladder. And then hesitancy, again, getting in there, feeling like you have to go, but you can't get it out. It takes a while to get started. And then straining. And so we'll talk a little bit about a few of the things that we can do. So here's another picture of the bladder here. And this is basically exactly what we discussed. So this is the bladder. This is the whole bladder muscle surrounding here. And this is the urethra. And so this muscle that is the bladder itself is called the detrusor muscle, and that's what contracts when you have to urinate, and that's what gives you the signal that you have to go to the bathroom. And so this sphincter muscle is closed when you don't want to urinate, but when that starts contracting and you have voluntary control, you actually release the urine. This is a picture here of when the bladder muscles begin to contract. It basically relaxes that sphincter muscle and allows that urethra to open and the urine to exit out. Is there a question?
Yeah, is this because that is the weakest muscle that we have? Is there like an exercise that we can do in order to strengthen it? Since it's so weak and it's so hard-headed to do its own thing, is there something that we can do to strengthen that since it's creating such a problem?
So there are exercises that can be done to strengthen the muscles of the pelvic floor. There's not a specific exercise that can be done to strengthen the bladder muscle itself, the detrusor muscle, because really that muscle's function is to help you empty urine, and you don't really have voluntary control over the detrusor. You have control over the sphincter muscles. And so there are special exercises called Kegels and pelvic floor therapy, and so we'll talk about that. That's an excellent question. So this is a picture of the bladder ultrasound, and a couple of the tests that you may have experienced in the office would be things like a urinary evaluation, so a urinalysis, where we want to collect a urine sample to see if you have an infection, send it off for a culture. We also want to do the bladder ultrasound, like I said, to make sure, is it a problem that you're retaining a lot of urine, or is it no, you empty okay, but it's more the opposite problem where you're having that frequency and urgency. And then sometimes if that's inconclusive, or we've tried something for your bladder, but you don't quite feel that it's cutting it and it's not helping, then we certainly would want you to be evaluated by a urologist. There's actually a wonderful urologist that we work very closely with. Some of you may have met him. His name's Dr. Shaw. He is a MS specialized urologist, which is pretty rare. So I know I worked with him when I was over at Ohio State, and then when I came here, I still sent a lot of people to him, and then the good news is that he just came here, so I get to see him more and work with him with my patients. And if anybody's ever met him, I think you can probably speak very highly of him and his skills. So he sometimes does this urodynamic testing where they actually push fluid into the bladder and then see how your bladder empties, and that helps to tell us more information about where the problem is. So we're just asking about what are some techniques or things that I can do on my own without actually taking a medication into my body. Well, fluid titration. So it's pretty common that you want to stay well hydrated and drink water, but I hear a lot of times people tell me, you know what, I'm going to the bathroom all the time. And I ask, are you drinking a lot? Oh yeah, I'm drinking a ton. You see this big water bottle I have here? I just keep drinking it all day long. Well, you might want to think about, it's good to stay hydrated, but if you're going too frequently, you may want to cut back just a little bit. And I know that's hard sometimes when you're trying to stay hydrated for other reasons, like maybe you have headaches or something of that sort, but maybe cutting back a little bit might help. The big bummer is that caffeine is a bladder irritant, and caffeine is one of my favorite things on the earth. And so that one's tough. But definitely if you're drinking a lot of caffeine, you probably notice that you have to go to the bathroom more when you have that in your system. And so that's just a balance. If you're going to have your morning coffee and then not continue to drink it throughout the day, that might be just fine. But it's really up to you, but just pay attention to that. Certainly alcohol will make us go to the bathroom more, and that's something to watch. And then citrus juices and artificial sweeteners can irritate the bladder and make you go more frequently. And so that's something that we don't always think about. It's been recommended that if you have nocturia, or you feel like you have to urinate at nighttime, that you actually consider cutting off your fluid intake about 2 to 3 hours before bedtime, because if you do that and then you empty your bladder right before bedtime, there's a better chance that you're going to sleep longer before you have to wake up to urinate, and maybe you'll wake up less. And so that's something to think about. Timed voids are important. How many people have heard about timed voiding? So it's a technique that sometimes sounds kind of obvious, but until you think about it, you may not have even considered this. So if you have a problem with urgency and you get kind of nervous that, gosh, when I'm at work or I'm out with my friends, I get these urges and I've got to get there really fast, I always recommend trying this technique. So do it on a day when you don't have a lot to do, and wear a watch and either set your alarm or just pay attention, and start out by making yourself go to the bathroom. Maybe you're going to start by saying, whether I feel like I have to urinate or not, I'm going to go to the bathroom every hour. And you go and you sit on the toilet and you feel if you can urinate or not. And if you can't, then that's fine. Get up, go back out. Repeat it. If you do that every hour and you find, gosh, I really don't need to urinate, I'm going to stretch that out. Let's do every hour and a half. And that works, and you do have to urinate. You may find that you're beating the urge. You're emptying your bladder before you're going to get that urge. So for some people, that sweet spot may be every 2 hours or 2.5 hours, but some people may need to go more frequently. And I realize that can be kind of annoying because you might not want to go to the bathroom that many times, but at least it is nice because you can beat that sudden urge where you have to run and might have incontinence. So that's something that a lot of people find really helps and works. So how many people have heard of Kegel exercises other than my brief mention here? So that's something that can be incredibly important because as we age, the muscles of the pelvic floor can actually become weak. And certainly for women, if they've ever had children, that's something that also makes those muscles very weak. And so it can add additional issues to the bladder problems and make it harder for you to hold that sphincter tight when you're trying to get to the bathroom. And so there are exercises both for men and women that can be done. And there are actually special pelvic floor therapists who can teach you these exercises and help you to get there. And so I've had the pleasure of working with Karina, who is a neurophysical therapist over at Larwell in Upper Arlington. And she's one of very few specialized pelvic floor therapists for neurologic conditions. And so I've seen a lot of patients who've gone to her and felt that they had significant improvement, and we're very excited about that. And so I know bladder is one of the worst issues that people can have with MS and can make you very limited in terms of wanting to get out and about. So there are lots of medications. I just like this cartoon, so I put it up there. So for overactive bladder, the most common medications are ones that are basically going to help to relax that detrusor muscle that's contracting frequently. These are things like oxybutynin, sulfenacin, tolterodine. You may have heard names like ditropan, Detrol, Toviaz, Sanctura. So these are all different options. One of the limitations of these medicines is that they can give you dry mouth. And so that's something that sometimes limits their use, and sometimes people feel that they're very helpful and sometimes not. Most of these medications have an immediate release, which is covered pretty well by insurance, and so they're often either twice a day or 3 times a day medicines, but sometimes we can also get them to approve a once a day, and so that's neat and definitely something to try if you're found to have issues with overactive bladder. Other medication options for difficulties with emptying. So if we find that you come in and we do our bladder testing, our ultrasound, or you go to the urologist for the formal urodynamic testing, and we see that you're having problems with emptying, there are several medication options that we can use to actually allow that sphincter to relax and allow you to empty better so that you're not having the problems with retention. So Flomax or tamsulosin is the most common one, and that one, again, was actually initially invented for benign prostatic hypertrophy in men. So prostates enlarge as many men age, and that can cause problems with emptying. And we always want to make sure that our males, if they're having issues with emptying, that that's been checked and addressed by their primary care doctor to make sure that it's not something separate from MS that is adding to the problem. And then certainly there are several others, and so these are all options. One of the tough parts about these medicines is, again, they can make somebody feel like they have dry mouth. Sometimes they can cause someone to feel dizzy, and they can also affect the blood pressure. And so somebody could become very lightheaded. And so it's a careful balance of starting at a very low dose and making sure somebody tolerates it. So there are a lot of additional options for overactive bladder, and you may have heard about some of these. So Botox is actually something that many urologists offer as a treatment for this. And it may sound kind of strange, but what they do is they actually use a special scope called a cystoscope to go through the urethra into the bladder, and they inject Botox directly into that detrusor muscle. So we saw the picture of the bladder and how it's this giant detrusor muscle. And so they do several different injections throughout that bladder muscle, and that actually helps to relax it so that it's not over contracting. And so that can be very helpful, and I've seen some of my patients just have a significant benefit with that. The neat thing about Botox into the bladder is that it lasts a lot longer than it does into muscles in the arms or the legs. So it can last 6 to 12 months depending on the individual. And so it can be very, very helpful. But we need to also make sure that if somebody's going to undertake that they're willing and able to use a catheter if their bladder's too relaxed. So there's a possibility, a risk with this, that somebody may have difficulties with emptying. And so before somebody would do this, we'd need to make sure that you're comfortable with that possibility, because if your muscles were so affected by it that you didn't actually push that urine out, then you might have to catheterize for a while. But usually, that's not an issue for somebody who's able to empty. Do you have a question?
Yeah.
Yep.
Isn't there a natural system in the bladder where it switches back toward between squamous flat cells and the top column there to make the circumference change in the bladder overall?
So there are different cells in the bladder. It's been a very long time since my pathology days, so I'm not going to get into that tonight. But it's basically with the picture that I showed you here, if we go back, your muscle, when the muscle contracts, it definitely shrinks that. But I think if you're talking about changes in the cells over time, that's certainly something that, that can happen, but is not related to this talk tonight. So another option for overactive bladder is something called sacral neuromodulation. So you may have heard of the term bladder stimulator. And so I actually put a picture up of it over here. And so right here, you can see this person is standing from the side, and this is their bladder. And you can see these nerves coming down and through the sacrum and innervating the bladder muscle there. And so what urologists will do is actually, before they would implant this, they do a test. They put electrodes in this area, temporary electrodes, to see if somebody has benefit with these electrical pulses to allow for better control. And if they do, then they may consider doing surgery. So there is a stimulator that would need to be placed. So you can see this implanted stimulator in the sacrum here, and then this wire lead that goes down to those sacral nerves. And so that's something that urologists actually would test you for first, and then if you needed it, it would be placed. One of the limitations in the past has been that if you have this placed, that you may not be able to get MRIs, but some of the newer bladder stimulators, I'm told, are actually MRI compatible. One of the things that I found with those is that typically we can image the brain and the higher cord very well, but if we want to go lower, that could be an issue. Was that the question that you were going to ask? Yeah, absolutely. So that was a big limitation before, because we obviously need to get MRIs to monitor how you're doing from your MS. And so taking that away would be a huge issue. And so in the past, I used to not recommend those, but now, I think it's a great option for people who did the test and definitely showed benefit. There's also another neat treatment called percutaneous nerve stimulation, where it's actually kind of similar to acupuncture to the tibial nerve. Has anybody heard about that or done that?
But I know it as PTNS.
Uh-huh. So that's exactly what it is. And so what did you think of that?
It worked great for me for, I think, 2 years, and then it started to wane, and then I went to the Botox.
Okay. So yeah, I know this is something that our urologist, Dr. Shaw, the neuro-specialized MS urologist, that he's offered a lot. And I remember the first time I heard of it, I thought, is that really going to work? But actually the literature on it is quite good. The only issue is that you have to go in frequently for office visits.
Like every 3 weeks.
Yeah. So that's definitely something that could be considered. And then lower down here, this is a less preferred option, but if bladder issues have become severe and are refractory to treatments, certainly having a catheter chronically could be something that could be done. Sometimes we do things called a urinary diversion. So I can tell you that I've probably only seen that done once, where they actually divert the urine from exiting the bladder through the urethra, but maybe somebody has an ostomy or an opening that's made separately to drain the bladder, but that's in very, very rare cases. But chronic catheterization with catheters can be a challenge. So one of the things that was brought up is, I have a catheter and I get a lot of urinary tract infections, and so what do I do about that? Well, there are different types of catheters that we can use. So if you've ever been in the hospital and you had problems with urinating, or you had to get surgery, you've probably had what's called a Foley catheter, where they put a temporary catheter in directly into the urethra and it drains into a bag. And that can be done for a short period of time, but one of the problems is when you insert any device into the urethra, you're also increasing the risk of urinary tract infection. And so it's not preferred that if somebody with MS has severe bladder issues and they need to have a chronic catheter, to use a Foley catheter long term, because there are a lot of issues with infection and dilation of that urethra over time. And so typically what urologists will recommend is a suprapubic catheter, where they will surgically insert a catheter into the upper portion of your bladder right through your lower pelvic wall here, through the skin. And that can be very effective in reducing risk of urinary tract infections as long as it's cared for properly. Now, one of the troubles is if somebody's not emptying well, and certainly with having a foreign device inserted, that you're at greater risk for urinary tract infections. And so I completely hear what you're saying about having issues with getting your UTIs a lot. Some urologists decide for certain individuals that they need to be on chronic antibiotics to try to prevent those urinary tract infections. And they also have very specific rules about how frequently the catheter needs to be changed and all of that. And so that's definitely something that I think if you have one of those and you're having a lot of issues with UTIs and being admitted to the hospital, we need to consider maybe you need to be on a preventative, a prophylactic antibiotic, and then also following very closely with the urologist. Okay. So we'll jump into talking about the bowels. So bowel complaints are very, very common. This could be constipation, where you feel like, gosh, I have to go so bad and it's so hard for me to go. No matter what I do, I'm straining, it hurts, it makes me really uncomfortable, I feel bloated. And then there's also incontinence, certainly. So people that feel like they have a sudden urge to go, that can be a challenge with the bowels too. It's very hard to hold that if you feel like I have to go and you got to get there fast, and very embarrassing to the person that it happens to if you have a bowel accident or leakage of stool. And certainly you can swing back and forth, so that's even more fun to try to deal with when you have MS, because you're trying to take medicines to keep your stools soft enough so you can pass them, but then at the same time, sometimes they're too soft, and then you don't want to go anywhere because you're going to have an accident. So it's a really fine balance of those two issues. And so this again is a result of impairment of neuronal control over the bowels. And so if you've ever had lesions in your spinal cord, it's possible that this neurologic input to the bowels has been impaired. And that may be a reason why you're having with constipation and emptying and that sphincter function. And it can also make it very slow for the stool to actually move through the bowels if that innervation is off. And so we need to do things to try to help with that. Certainly in MS, if you've had spinal cord lesions and you've developed weakness in your core muscles or the abdominal muscles, that can actually make it harder to empty your bowels. And so that's something to think about. And that's what many of you may have heard a lot about, the importance of core strength if you've done any of the MS wellness programs, or just, in general working out. It's very good to work on strengthening that core because that helps your overall balance. But in our discussion tonight, it actually helps for you to empty your bladder. Now, decreased physical activity, that's a tough one. So, sometimes with MS, you may be more limited based on function that's been taken away from the MS, and so it may be harder to be as active or up and about as much as you were before. Or you might just feel fatigued, and so you're not exercising as much or doing as much as you would like. And so not being as active physically makes you feel more constipated. And so that's something that I see a lot, certainly when anybody's in the hospital. It's a challenge. You're stuck there sitting in a bed for a long time, and you're not getting up as much, and so the bowels get stopped up. Again, there are lots of medications that can actually worsen constipation. So some of the bladder medications that are used for overactive bladder or emptying the bladder that have an anticholinergic effect can make that constipation worse. We also have seen that pain medications can make the constipation worse. And so certainly if you've had a surgery or anything requiring narcotic pain medications, that's a big one that can really stop up the bowels. So we always want to look at the medication list and see what are the medications that you're on, and are there any offenders, maybe something that we could adjust. Laxatives to treat constipation can help if somebody has impaired function at the external anal sphincter. And so there are lots of things that we can do. So I thought this was interesting that there's an official definition of constipation. I think it's one of those things, it's like you know it when you have it. So I don't know that there needs to be an official definition, but I thought we'd talk about it because it's interesting. Actually, what people think is normal as far as bowel movements is very different across cultures. So in other countries where they eat a heavily plant-based diet, having a bowel movement 3 times a day could be completely normal. Here in the United States, some people are lucky if they have a bowel movement once a week. But really, I think that what matters is your comfort. And if you're able to move the bowels, if you're not feeling bloated, stopped up, then I think you're doing well. So the formal definition is that you have to have at least 2 or 3 of the following. So you have to have less than 3 bowel movements per week, hard stool about a quarter of the time, a feeling of incomplete bowel emptying over 25% of the time. So that means you have a bowel movement, but you feel like you still have more in there and you just can't empty it at that time. Excessive straining with bowel movements. So that's always a tough one. You're trying to empty your bowels, but you don't want to do that because then you can develop hemorrhoids that are very painful, and those can be a major other issue that needs to be addressed. And then certainly anybody who's so constipated that they actually need to disimpact their own stool. So to actually use their finger, hopefully gloved, to try to remove stool. And that certainly is something that sometimes is done in the medical profession when people have severe constipation. So these are some of the medications that can contribute to constipation. So we talked about some of the bladder medications like oxybutynin and tolterodine, the Detrol, the Ditropan. Antihypertensives, some of them can contribute. Pain medications, we talked about narcotics being the most common. Actually, some antidepressants could contribute to constipation. Yes?
What about just regular
suggestions for those of us who take pain medications every day?
So things like ibuprofen and Tylenol generally should not contribute to constipation. So those types of things I think would be okay. So sedatives, diuretics, and iron. So if you've ever been iron deficient and had to take iron, that's a big one to bind you up. So that can be a challenge. And then there are other medicines that may promote the opposite effect. So where you're having too loose of stools. So sometimes antibiotics can do this. So you're on an antibiotic for your UTI that you're having, you have to go to the bathroom all the time for that, and then your antibiotic starts making you feel like you have diarrhea and you've got to run to the bathroom, so you're kind of stuck between a rock and a hard place. Some antihypertensives, certainly laxatives, that's very obvious, antacids, and some other diuretics. So how do we treat constipation? Well, there are a lot of options, and usually we want to start with the most basic behavioral changes before we start introducing more medications. And so one of the best things that we can do is to be more active and exercise as best we can with our abilities. We want to make sure that you're staying hydrated. Certainly bulk forming agents, so agents that have fiber to try to bulk up that stool, can be helpful to allow you to empty more easily. And so certainly you've all heard of things like Metamucil, Fibercon, Benefiber, Citracel. Those are all good options. And then there are over-the-counter stool softeners that you can take. So Colace is one of them. That's something that is not a medicine that you want to just wait and take when you feel constipated. It doesn't really work that way. It's not like a laxative. But if you're somebody who's generally constipated, you may want to consider just taking that as part of your regular medication. So maybe you can take it in the morning, in the evening, or just once a day, whatever works for you. But that helps to soften the stool. There are also stimulant laxatives. So medications like Senna, I'm sure many of you have heard of that. That's something that you can take to try to stimulate that bowel movement. Other medications like bisacodyl or even castor oil. And then there are the various laxatives. So how many people have heard of or used Miralax? That's actually a great one. I know, you're really proud to raise your hand in here tonight. You're like, this is kind of embarrassing. Don't worry, you're not on the videotape. So as far as the Miralax, that's something that actually works really well and is pretty safe. It's so safe, it's something that actually pediatricians recommend even in babies and kids for constipation. So, I have many patients who actually will take that every day just to help regulate their bowels, and that's okay. But that's also something that if you feel like you're doing pretty good on some of your bulk forming agents, the fiber agents, and eating a good fresh fruit and vegetables diet, that you may only need to use something like the Miralax once every now and then. It just really depends on you and your body. And then there are other types of laxatives, so saline and lubricant laxatives, and those are, certainly in the form of enemas. And so sometimes when people have severe constipation, that's something that we can use. One of the tricks for incontinence that I learned a long time ago, this one's a tough one. So if you don't have the ability to feel that you need to empty, or you have bowel urgency and you're worried about going outside the house because you have these accidents, and that can certainly be very embarrassing, you can try to take back control of your bowel movements by actually taking suppositories or enemas maybe in the morning. Certainly you don't want to do it 30 minutes before you have to be somewhere, but you want to try it the first time on a day that you have several hours to be at home, and kind of see your timing of, if I do this, how soon after am I going to have my bowel movement? And so for some people, that's how they take back control and empty their bowels before they go out for the day, so they don't have to worry that they're going to have an attack of urgency and have incontinence. So again, treatment of fecal incontinence, we want to eliminate those dietary irritants. I know a big bummer about the caffeine and the alcohol. You can use caffeine to your advantage for constipation. One of the nurse practitioners that I worked with when I was in my fellowship, Mary Pat, always used to say, all you need is just a hot beverage. So hot coffee, if you like coffee, hot tea, anything like that. You may find that when you drink that in the morning, that helps to regulate your bowels. It doesn't work for everybody, but a lot of people say, yep, I have my bowel movement right after I do that in the morning. So not only is it delicious and good, but you can move those bowels. We also want to think about if you're having fecal incontinence, a big thing that can contribute to that is muscle relaxers. You know, a lot of people that I meet with MS tell me that at night they have a lot of spasms and it keeps them up and it's uncomfortable, and or they're really stiff in the morning. So we try to use things like maybe baclofen at bedtime or tizanidine. But then as we increase the dose, I've seen a few people who say, yeah, I actually had some incontinence in my bowels, and I didn't even know it when I was sleeping, or had noticed that with higher doses of muscle relaxers. And because that sphincter is a muscle, if we're relaxing it too much with those medications, then that's a possibility. And so we want to just be aware of that, and that's something that could potentially be adjusted if you're having that issue. Interestingly, some of the anticholinergic meds used for bladder can actually help bowels if you're having bowel hyperactivity. So that's something that could be considered. And then again, pelvic floor therapy can also be helpful for bowel incontinence, not just urinary incontinence. And there are actually biofeedback techniques that can be used along with that to help you perhaps have better control, and then also better rectal sensation to know when you're going to have that bowel movement, even though your sensation may be very altered. Now, when it's very severe and somebody doesn't have the ability to feel the bowel movements, they just have incontinence, rarely fecal plugs could be used to try to prevent that emptying at unwanted times. And then certainly sacral neuromodulation that we talked about a little bit, so the bladder stimulator can also be used for the bowels. And some of the urologists that I work with who do that for the bladder, they also are very interested in knowing if somebody's having bowel issues as well, because they may consider using that for both. And then certainly if it's very severe, we want to involve our friendly gastroenterologist to see if there are any other ideas or recommendations that they have. So I thought this was a nice table. This is actually an algorithm that was developed by the consortium of MS centers. And so this is just overall for constipation, so kind of informing healthcare providers how we should consider going about these different options. So I don't know if you can see this too well. I'm sorry it's a little bit small. But on this side, the boxes are talking about individuals with MS who are able to walk. And then on this side, it's talking about individuals with MS who aren't able to walk. And so for those who are able to walk, you know, certainly considering bulking agents, avoiding sugar, alcohol, and caffeine, and considering a referral for pelvic floor therapy and biofeedback. For those who are immobile, develop a bowel regimen, trying to evacuate early. And I'm sorry, this management of constipation, this should say management of bowel incontinence. Trying to basically beat that emptying time, timed eliminations, use of laxative suppositories, and cautious use of antidiarrheals. And then again, involving physical therapy to optimize mobility and occupational therapy. If there's no response to any of these attempts, then certainly somebody should be referred to a GI specialist. There was a study that actually showed that bladder and bowel symptoms were one of the least treated and addressed symptoms in people with MS. And they think there's several reasons for that. One reason is that it can be embarrassing to bring up. One reason could be that sometimes doctors or other healthcare providers don't ask about it, and so people feel like they shouldn't bring that up. This is just something I have to deal with. And then there's also a lack of knowledge amongst healthcare providers of what to do for that. Because they think, well, gosh, the neuronal control is knocked out, so how do I help this person? I feel like there's nothing I can do. And so just being aware that if you have these issues and they haven't been addressed, you can always bring it up. And if there's nothing that has helped so far, request a referral to one of these specialists, because they may have additional options for you. So for management of constipation with bowel incontinence, this is again formal recommendations. So for people who are able to walk, first thing we talked about, we want to do lifestyle recommendations, use bulk forming agents, appropriate fluid intake, start exercising, avoid sugar and alcohol, and have a timed bowel regimen. If those don't work, then to be evaluated by a gastroenterologist. And then for people who are immobile, if a rectal exam is done and there's fecal impaction, so meaning that they're very stopped up and you have to manually disimpact, that's certainly a reason to involve a GI specialist. And if there are no abnormalities, certainly to start that bowel regimen of treatment and consider PT to optimize mobility. So we're going to jump into talking about the birds and the bees. And one of my nurse practitioners threatened that she was going to come here and ask me all kinds of embarrassing questions. But first I'll answer a question.
I was going to make a comment to see if anybody would like to know,
Going to a pelvic floor physical therapist can be a life-changing experience. And I didn't even know they existed, and I didn't know that they worked for the constipation side of the universe. Talk to your doctor. Oh my God, it made a difference.
Thanks for sharing that. It's interesting because I think a lot of times when we bring up that, it sounds kind of weird, and you think, what are they going to do to me, or how are they going to help me? But I'll tell you, the number of times that I've heard that same statement is incredible. And so it's not something that I actually even used to use because I didn't know about these people either until I came over here to Riverside. So it's a really neat option because we certainly want to minimize medications and try more of these interventions to try to fix the underlying issue. So sexual dysfunction is very, very common. It's very common in MS, and that makes sense because just like we can have interruption of the neuronal control to our bladder and bowels, we can also have interruption of the control of sensation in the perineal region. And so that can cause problems with primary dysfunction in regards to demyelination. So if you've had demyelination that's damaged these neurons that control sexual function, then you may not actually be able to engage in sex. So for instance, if a male has erectile dysfunction related to neuronal damage, that can be a major challenge. And so there are many things that can be done. So certainly medication options that have been developed have really focused on male sexual dysfunction. And we're not really clear on the benefit that those medications have for females, although there have been some studies that have shown that some of these medications can actually help. And we're talking about things like Viagra or sildenafil. And so that's an option. One of the tough parts about that is that it's very expensive, and a lot of insurances actually don't cover it. And there are coupons online to get copays, but I hope that someday we'll be able to overturn that because it is a medical issue and a quality of life issue, and not just some extra thing that, oh, if people actually want to have sex, they should pay for this out of pocket, like it's a bad thing. So there are these different degrees of sexual dysfunction. So the secondary causes of sexual dysfunction are not just primarily from that damage that's occurred, but it's because you have a lot of other symptoms that are interfering. So in MS, most people have fatigue. If you have fatigue and you're really tired, that may affect your libido and your desire to actually engage in sexual activity. If you have cognitive problems, if you're weak or you have spasms, you may not feel like doing that. I have a patient who came to me a couple years ago who said that every time that she even tried to wipe in between urinating, that her legs would spasm and they'd stick together. And so she couldn't even separate them, and so she couldn't even be with her husband of 15 years, and that was a big problem for them. And so by controlling those muscle spasms, she was again able to do that, and that was very important for their relationship. Sensation. So if you're numb, I always say if you're numb in the down there's, it's probably going to be not so enjoyable, or you're not going to be able to feel what's happening. And so there are different things that can be done. And some of these things sound embarrassing. I've tried to show people websites that we've looked at that have been recommended for people with neurological dysfunction. And there are websites that sell, obviously, things like vibrators and lubricants that can help when there are problems with sensation. There's one website that we usually give to our patients who ask in the note, and it's called goodvibes.com. And so that's one that you could look at. We tried to pull it up for a patient at Riverside, but they block us. It's like pornography on the internet, so I can't pull it up for you. Which is funny. I think someday I'm going to get a call. Why are you looking at this during work? So that's something. And then certainly another interesting device that I don't even think a lot of doctors are aware of is something that was FDA approved for female sexual dysfunction. So particularly for females having difficulty with orgasm. So the device is called the Eros device. It's spelled EROS. And you can buy it online. Interestingly, I found out the other day that it can be bought from Amazon. The last that I heard, it actually required a prescription, but I think now you can buy just about anything on Amazon. The Amazon one was very expensive, but this device was developed for female sexual dysfunction. And what it is, it's actually a suction cup type device that's actually placed over the clitoris and then pulls blood into that area and helps with sensation. And so that's something that I've had many patients who have obtained that and actually felt that that was very, very helpful to them. And so I know that certain insurances do cover that with a prescription from your doctor. And there's the website, I think it's eros.com, actually talks about some of those diagnosis codes that could be used. So that's something certainly for our females to consider. Medications. So many of our medications can impair sexual function. So the biggest one is some of our antidepressant medications. So depression and anxiety are very, very common in MS. And obviously if you're depressed or super anxious, you're probably not feeling very sexy and wanting to have that libido or drive to actually have sex. But then if you treat it and you knock that out completely, that's a big problem. So I always caution my patients when we use medications like SSRIs that's a potential risk. And so we try to use the lowest dose that's effective. And then certainly there are some antidepressants that are less likely to have the sexual side effects than others. So one of those medications is something called Wellbutrin. That's a really great medication for depression, not so great for anxiety, but it is something that many of my male patients and female patients with more of a depression than an anxiety have found to be really helpful. If you're on one SSRI that has kind of knocked out your ability to orgasm or your drive or libido, then you could always try a different one, and that may not be that may not impair you as much. And then certainly medications that make you more tired. So how many people have ever heard of gabapentin? I'm sure it's probably most people in the room. Gabapentin, baclofen, tizanidine, all of these medications can make you very, very tired. And so again, if you just want to go to sleep, you're probably not going to be engaging in sexual activities or feeling as much that's something you want to do. So it's something to think about and look at. And pain, that's a big one. If it hurts for you to engage in this, so maybe you have lost sensation or you have burning sensation on your legs or even your pelvic region, maybe that's something that could be addressed better with a neuropathic pain medication. And then certainly there are problems with actually pain during sexual intercourse, and that's something that could certainly be addressed in coordination with your gynecologist or your primary doctor, and sometimes using things like lubrication and having that evaluated. Sometimes certain creams that may be prescribed by your gynecologist could be helpful, and so lots of things to think about there. And then there's tertiary, so all the other things that factor into it, your psyche, psychologic disturbances, negative self-thought, thinking, I'm embarrassed, I don't want to do this because I feel like I'm not beautiful, or other things. Anxiety, depression, fear, guilt, having low self-esteem, and certainly family interrelationships. And so sometimes the issue is not as simple as, oh, I have MS and I developed damage in my spinal cord, and so now I have sexual dysfunction. Sometimes it's a lot of other factors. Maybe it's that I have severe depression and anxiety, and that's driving it. I have found a lot of times by treating that many patients have said they had improvement in that area.
Why specifically were you referring to talking to a gynecologist? Some of us haven't seen one in years.
Mm-hmm. So I think that you should be seeing one as a woman, even if you're not having babies anymore. It's actually very, very important for your overall female health to be evaluated. And so the reason is that sometimes if you have low levels of estrogen or progesterone, or you have gone through menopause, you can have a lot of dryness. And so there are sometimes hormonal medications that may help to help with that sensation and to have less pain and discomfort. But definitely as a woman, you should still be regularly examined and having routine mammograms for monitoring of things like breast cancer. So I think it's still very important to follow with them. So what are factors that affect libido? Well, I think we've talked quite a bit about them. So partner availability. So is your partner busy all the time? Are they never around? Are they not around when you're awake? And then you're tired at the end of the night. So maybe you need to think about scheduling that time. So maybe you're going to plan it for the morning. I know that sounds weird, planning, but it's a busy time. You plan meetings, you plan to come to your doctor's appointments. So why not plan when you're going to be together with that certain someone? Personal well-being. Certainly depression, we've talked about socioeconomic circumstances, stresses about work, about finances, performance anxiety is a big one, and certainly medications. There actually are several psychologists who specialize in sexual counseling and sex therapy that individuals can go to, or even couples can go to. And I have had many patients who found that to be beneficial. And so sometimes it can be hard to talk someone into doing that, but I think that if there's a psychological component or this performance anxiety, some of these other interpersonal relationship issues, that can be very important. And then we certainly need to address all those symptoms that we talked about of MS that can be related to the sexual dysfunction. So one of the biggest symptoms that correlates with sexual dysfunction is bladder dysfunction. And one of the biggest reasons that people with MS have said that is, or they think that is because they're worried if they have bladder problems, are they going to have to urinate? Are they going to have incontinence of urine or bowel when they're engaging in sexual activity? And so making sure that you talk through these fears and see what can be done, and that's something that you may talk about with your partner. And then certainly we've addressed all these other points before. So treatment, again, is to address the underlying cause. There's usually not just one cause, but many different factors that play a role, and so really talking through that is important. We talked about counseling. Certainly devices like vibrators or stimulation could be used for people who have difficulty feeling that sensation, to enhance sensation prior to sexual intercourse. And then also there are treatments for erectile dysfunction. And I have a funny story. I know back when I was in training, one of my mentors actually told me that he was going to the airport to give a big talk at one of our big MS meetings on sexual dysfunction to a bunch of doctors. And so because of this, he decided he was going to bring this big suitcase full of all kinds of funny things like vibrators and, you name it, things that I shouldn't say on this camera. And he got stopped, and they wanted to examine his bag. And so they opened it up, and they're pulling all these things out, and they're just looking at him like he's a horrible guy. And then he's like, I swear, I'm a doctor. I'm going to this conference. And they even look at him worse. And I'm giving a talk. They're like, sure, just take your bag and move on. So anyway, so I'll go ahead and stop there. And I'm happy to answer any questions that you have about what we talked about tonight or MS in general. And thank you guys so much for coming and for all your great questions tonight. Yes?
I experienced, I don't know if this falls in some of this counseling, but I found sort of stepped backward into this is cuddling.
Mm-hmm.
It seemed like that is wonderful, and I didn't realize, I can't get an erection for one thing,
Mm-hmm.
but that seemed to do the job. But then it was perfect until I started getting feelings that mistrust. I just wanted to know. I just couldn't imagine that she wanted to stay with me with all my problems with MS and, you know.
Yeah, so
That's
that,
something I have to work out, and I don't know how to go about this.
well, I think that's, thank you so much for sharing that, because that can be a major issue. So, if you think about, some of the issues that you have related to your health problems, and you think, well, gosh, maybe this person isn't, they could have anybody, so why would they be with me?
Yeah.
And I think that's definitely something to work out. And I think that this type of counseling would be really important for you, because that'll help you to build that self-esteem and that trust in your relationship, and to know, you know what, I am a really great person. I'm a catch, and it's not that just because I have MS and I have these issues that, I'm not as desirable, and that my partner really does love me and care about me. And so I think that that's something definitely that needs to be worked out, and I think counseling and talking with your partner about that is important. But I also like the fact that you bring up that there are other ways to be intimate. And so, cuddling, spooning, those sorts of things can also be very intimate.
What type of a counselor would I look for? What type?
So many psychologists would be able to help you with this, that would give you counseling in this area. And there are actually psychologists who specialize in couples counseling and in sexual therapy. And so I don't know if you see anybody here in the MS Center or where you see your doctor, but you could also ask them for a referral. All right. Well, thank you guys so much for listening and not turning my face bright red. Nice meeting you. Oh, one more. Okay. I'll try to keep it pale and white.
I'm having problems with the fact of intensity of orgasm. I mean, it's like, yeah, I can still orgasm, but it's nothing compared to what it used to be. And I feel like I'm faking it with my husband all the time.
Mm-hmm. So you actually have orgasms, but they're not as good.
They're minor paltry little, almost non-existence, but I still acknowledge them as an orgasm, let him know that, yeah, I had an orgasm and everything for him, but I'm not having that intense sensation, and I have a lot of problem with a lot of tension in my body, and I just talk with my counselor, and my counselor specifically says, okay, you need to find some ways to have relief tension. I suggest you have sex with your husband. It's like, okay, how do I have the orgasm I need to have? And my counselor is specifically saying I need to have.
Is your husband paying this therapist? No, I'm just kidding. I think that that's definitely something that I've heard before. And certainly with MS, you can have problems with sensation in those connections where you may not feel it as intense. But I would recommend, if you haven't already, consider using things like lubrication or other creams that may heighten sensation in that area. Also, sometimes foreplay longer before sexual intercourse can help. And then also some of the vibrators and stimulators is something that can be used. Okay, so great questions, and thanks for turning my face red before I left. I said I wasn't going to do it. All right, thanks guys. It was nice seeing you tonight.
Thank you.
You're welcome.